So what I've done this evening is go through a little bit of a brief overview of bladder cancer and the treatments. And obviously I wasn't quite sure what the audience was and what they wanted. So just kind of stop me at any time. And if we don't get the whole way through, that's not the end of the world. We can always do another one at another time. So I've kind of gone, not knowing what your previous speakers have talked about, just a few kind of like introduction slides first. Obviously, as a lot of you know, the main risk factor for bladder cancer is smoking, which is thought to account for about 50% of all bladder cancer. However, a lot of my patients are still non-smokers and often don't have any risk factors at all, so we're not quite sure what's caused it. Some other things that can increase the risk but are not relevant in many people is people that have worked in an industry using a lot of chemicals, so hairdressers with a lot of dyes, or people working in a dye clothing industry dyeing clothes. Occasionally someone gets a bladder cancer because they've had treatment in the past with a drug called cyclophosphamide, like a childhood cancer or leukemia or something that they've needed immunosuppression for, and then at high risk of cyclophosphamide, but it's pretty uncommon. Or people that have had chronic infections or inflammation in the urinary tract or bladder stones. So things that are constantly irritating the bladder can make you more prone to getting bladder cancers. But as I said, lots of my patients have none of these risk factors whatsoever, and we're not really sure what's driven it in a lot of people. So the demographics, as most of you know, this is taken from the Cancer Australia website, is that there's a large predominance of men that are affected with bladder cancer. And they've said out of approximately every 3,000 people that are diagnosed, 2,400 are men and only about 700 to 800 are women. And it accounts for approximately only 2% of all new cancers diagnosed. And this was estimated for this year, for 2020. So as many of you probably know, the main symptom is usually that you pass some blood in the urine or see discoloration of the urine. It may be associated with some urinary frequency or urgency, being unable to control the urine, but often there can be no symptoms at all. And I've seen a lot of people where it's been picked up almost by accident. So in women that have had a pelvic ultrasound for some reason, and then there's noticed a spot in the bladder, or in men when they're having investigations for a raised PSA or a problem with their prostate, that on the way through with a surgeon doing going to do a prostate biopsy, they notice something in the bladder. So they can be picked up together. So what tends to happen next? Most of you probably know this, but most people will be seen by their GP. Their GP might do a urine sample, firstly probably to look more for a urine infection or possibly kidney stones causing blood in the urine, but also the urine can be examined to see if cancer cells are kind of floating in the urine and can be detectable just by doing a urine sample. And then the next step is usually that you see referred to someone like Carly, so to a urologist who can investigate this further. Jump in whenever you want, Carly. And from that point, depending on what the urine sample might show, it might be that you have to go ahead and have a cystoscopy to look inside the bladder with some biopsies when there's an abnormality seen. At some stage, you normally will have had a CT scan or an ultrasound looking further up, so up to the ureters which drain from the kidneys to the bladder, because as you may know, the same cells or the same lining tissue is inside both the bladder and the ureters leading up to the kidney. So sometimes cancers can occur at multiple spots in the urinary tract at the same time. So this is a little overview, a picture I often show people of the stages of bladder cancer. I'm not sure if you can see my cursor there, but this is showing basically the bladder being almost like a balloon. So the urethra here where you pass urine at the bottom, and then they're showing the layers of the bladder. So the red in the middle is where the urine usually is, and then showing the surface or like the skin of the bladder almost. Then the next layer with the pale pink and the little red dots is the muscle, and then the fat around the outside. And then these images showing the various stages within the bladder. So the earliest possible being in the bottom left being the TIS, which is the in situ cancer cells. So that will just be when the cancer is growing in just this surface, but not really forming much of a tumour yet. And then going through TA, where it's kind of protruding into the bladder, but not really getting any roots to go any deeper. And then as you go around, getting deeper and deeper into the bladder. So the T1 growing into a little bit under the surface, and then the T2, 3, 4 around the outside, getting deeper into the bladder and even through the bladder wall. And this is really important when we look at what the best treatment's going to be. I kind of liken those very early bladder cancers like the TIS, the TA and the T1 almost to being like a skin cancer on the surface. So the primary role being to remove them, but they do have a chance of coming back. So as you may know, if any of you have got the early kind of bladder cancer, all of those early ones are kind of bundled together in what's called non-muscle invasive bladder cancer. So they're the ones that are on the surface. They might have some very early roots into that first layer, but they're not going deeper into the muscle. And also known as, you might see written down or read about, superficial bladder cancer is kind of the same thing, but the terminology was changed a little while ago. So the treatment for these non-muscle invasive bladder cancers primarily is to have them removed. So seeing the surgeon, having a cystoscopy and then removing anything that they can see. And then based on how aggressive they look is whether it might be best to have some treatment given into the bladder afterwards to try and reduce the chance of the cancer occurring. And that's called Intravesical, which just means into bladder treatment. So going back to this picture, it's these ones here, the TIS, TA and T1 that are included in this group of the non-muscle invasive or superficial bladder cancers. And once it gets further with some deeper roots, the treatments are quite different. So I'll separate those two sections out. So when we look at these treatments given into the bladder, and as I understand from Chris and Carly, a lot of the questions are about some of these treatments. The two things we commonly use, one is BCG, which we'll talk more about, or chemotherapy drugs. But it's not traditional kind of chemo. It's not like you're going to get the side effects of someone who has an intravenous drip and chemo going into the bloodstream. It's just it's going in just into the bladder. So main symptoms are kind of irritation of the bladder. And there's no hair loss and virtually no nausea. Sometimes there can be a little bit of fatigue, but it's not like having standard chemotherapy that people would have for other cancers. Method of delivery, however, is exactly the same. So it involves coming into, we do them through chemotherapy suites, but they're also done through ambulatory care units, or some people do them in surgical recovery, where you don't have an anaesthetic for the treatment, or not a general anaesthetic, but you do have a little bit of local anaesthetic given through the urethra just to kind of numb it so you can put the catheter in without it causing too much discomfort. And as many of you probably had the BCG know, is that it does cause a fair bit of irritation of the bladder, and that occurs much more so with the BCG than with chemo drugs. Treatments can actually be prescribed by your urologist or an oncologist. So I'm aware that it differs quite a lot from one hospital to another. In our centre, there's been an arrangement many years ago before I started working between the two teams that the oncologist would kind of run the Intravesical treatments. But in some places, I know the surgeons actually do this themselves or have a facility where they can actually do this. Carly, what happens at Macquarie? Do you guys do it, or does it go through to oncology?
I think oncology does it at Macquarie, but in the public hospital, urology does it.
Yeah. So whenever we kind of all talk as a group, there's a lot of oncologists that have had nothing to do with these treatments at all, depending entirely on where they work. And
sorry, go on.
No, as I said, I know some private urologists even have the ability to do it in like a room within the consulting suites.
Question. Just going back to the histology slide, what's the difference between high and low grade? Other way, oh yeah, there. What's the difference between high and low grade is the question.
Oh, so it doesn't necessarily kind of show it on here, but it's more under the microscope when the pathologist is looking at the cancer cells, and they look at features to see how aggressive it looks. So if the cancer cells look like they're they're growing really fast. There are some things they can detect when they're looking at the tissue under the microscope that tells you whether it looks slow or fast. And some of that's based on how many cells were actually like dividing and growing at the time of the biopsy. So they can kind of do it to account of, you know, say that 10% or 20% of the cells were dividing and growing at the time the biopsy was taken, or it might look like they're all actively dividing and growing at the time. So the pathologist looks at a couple of things like that to determine whether they think it's looking high grade or low grade, and also how abnormal the cells look. So low grade cancers tend to look more like normal tissue, so they'll look more similar to a biopsy of a normal part of the bladder, whereas the high grade will look very abnormal and might not even look much like bladder cells under the microscope. So that's something that comes back on the biopsy report.
Something else which I'm sure you're going to get to is what's the alternative treatment to people with BCG intolerance. I'm sure you'll cover that soon.
Yeah, so we'll kind of go through that. And also, and in more cases than not, it's because we can't get the BCG rather than the intolerance being the main issue. Yeah. So just go back. Okay. So this is just a little picture showing exactly what's done. And as a lot of you probably know, is they'll say, look, don't drink too much before you come for the treatment, because we're going to put a treatment inside the bladder and going to get you to hold it for a couple of hours. So we want your bladder pretty empty to start with. So a lot of people don't drink much the morning of the treatment or the night before. Number 2 here is they put the little catheter up through the urethra into the bladder. And they'll empty as much as they can of whatever's in there, but then the BCG goes through a syringe or the chemo, however it's given, into the bladder, and then they clamp off this catheter so that it can't come back out. And ideally get you to try and hold it for 2 hours. And so most times that's done while you're still waiting, or while you're still within the hospital or the chemo suite. And a lot of people kind of describe this as being on the rotisserie, so they have to roll around on the bed. And usually it's every 15 or 20 minutes, just a reminder to roll side to side on kind of front to back, so that you're sloshing the fluid around the whole bladder. Because as you can see in here, it kind of almost gets a bit of a bubble, or it pulls away from the fluid, and you can get patches of the lining of the bladder that don't get the BCG solution on them if you stay in the same position for the whole time. So that in some places the nurses give you a little timer and get you to roll around and turn. Other places you just set your own reminder to roll around during the treatment. Then number 4 down the bottom here is, once you've held for however long you can, whether that be an hour or 2 hours, the catheter gets unclamped and all the fluid comes out. The catheter goes out, and then you go home again, usually having been about 2.5 to 3 hours in having the treatment. In younger people that are possibly very fit and they're able to kind of make their way home and not be too busting to go to the toilet, sometimes after 1 or 2 treatments, you might have the solution put in the chemo suite or recovery and allowed to go home and do the rolling around on your own bed, and then go to the toilet at home. And that's usually done for the first time you're having the treatment, is done once a week for 6 weeks. So these are the kind of schedules of treatments you can have with intravesical therapy. So in some cases, if you're known to have like a low-grade cancer, and the timing of this is kind of that the surgeon's done 1 biopsy, they know it's low-grade and they're going back just to clear the bladder, they might ask to have a single dose of chemo put into the bladder straight after that cystoscopy. So basically while you're in your recovery, or the day that you're in afterwards, you can have a single dose given straight into the bladder of a drug called Mitomycin. And in some people, that actually stops the cancers progressing to high grade, or stops others coming back, and might be all that you need. And in the people that I've seen have this, I'm not often involved with the single doses. It's usually the surgeons. They kind of hardly even know it's been done. They're just in recovery, having their waking up to their anaesthetic and everything, and this treatment's done at the time, so it doesn't really affect them very much at all, and might prevent it progressing and needing the more intensive treatments. But for the majority of people that I see, they come to see me because they've been found to either have a low-grade cancer that keeps coming back, or it's kind of more aggressive and it's more of a high-grade cancer, and they're needing a longer course of treatment. And most people have what the first part's called induction, and that's when, as per the previous slide, where you do one treatment per week for 6 weeks. And it's usually the same drug every week. We don't kind of change between the weeks unless there's problems with it. At some stage, you might need a week off if you're getting lots of side effects or struggling to hold the fluid in the bladder for the 2 hours, or you might get a urine infection during it. And usually at the end of the 6 weeks, you then go and have a cystoscopy to check what the next step is. And occasionally this induction 6-week course might need to be repeated. And that's if at the next cystoscopy there's still something growing, or down the track something more aggressive grows, we might need to give the whole 6-week block again. But most people would have the 6, have their checkup and be all clear, and then go on to maintenance treatment. I know there was a few questions around maintenance, but it does vary quite a lot depending on the exact pathology, so how many tumours were seen, how aggressive they were. But typically, which I think is showing on next, in more detail on the next slide, the shorter duration for the low-grade cancers is usually up to 12 months of maintenance. But if it's high grade or there's lots of tumours, we might go out to 3 years, depending on how the treatment's tolerated. And might need to change the drugs or the schedule of the treatment if it's not tolerated very well, or obviously if more cancer's picked up at the next cystoscopy. So this is a kind of a summary of from the European guidelines of how long the treatment should go for, depending on what that pathology report shows. When you see the surgeon, they go through what was found. So in people that are considered to be low risk of something coming back, and that can be that there was just a single cancer seen that was low grade, and that there was no carcinoma in situ, which is the cancer cells growing in the surface, and no invasion into the deeper parts of the bladder. They may just have that single dose of mitomycin that I mentioned just at the time of their cystoscopy, and might not need anything further. And then I'll just kind of jump down to the higher risk, because you might notice in that middle box in the intermediate is kind of just the people that fall in between the low and the high risk. So with the high risk, it means that there's been a high grade cancer found, or it's growing a little bit deeper into the deeper levels of the bladder, or that it's come back multiple times. And in that case, we would consider it to be a high chance of something coming back down the track if you don't do anything other than surgery. And that's when we go through that 6 weeks of BCG induction on the right-hand column there, and between 1 and 3 years of the maintenance treatment. And for the people that fall in the middle, that's when we will often give just a shorter course of the maintenance. So someone who just keeps getting the low-grade cancers, or doesn't have any of those high-risk features, they might have a shorter course of maintenance and still be quite successful. And the reason for giving the maintenance afterwards is the induction, I kind of think, is the most important part of the treatment, but there's been quite a few studies shown that if you have the maintenance as well, it actually further reduces the chance of something coming back, and that's why we continue the treatment afterwards. And obviously at the bottom of the table, some people unfortunately fall into this highest risk group where the cancers just keep growing despite the BCG, and they might have had BCG and then tried a chemo into the bladder as well, and the cancers just keep getting worse. In that situation, we may need to look at more radical treatments like taking the bladder out with a cystectomy, or possibly considering radiation to the bladder, or a combination of chemo and radiation. So what drugs do we use? So most commonly we do use BCG, and as a lot of you may know, that's a small dose of a bacteria called Mycobacterium bovis. So it's basically giving like a little tiny dose of a urinary tract infection. And the way it works is it's kind of inflaming your bladder wall. So it's making your body think it has a urine infection, or it actually is giving it a tiny infection that hopefully it stimulates your immune system to go to the bladder to try and clear that infection, and activates the immunity to kind of kill the cancer cells itself. So it was one of the very early forms of immune therapy, in the hope that if we can make your body realize the cancer shouldn't be there, then hopefully your body will keep, basically mopping them up themselves, and that down the track, if little things start to grow, that your body knows that they shouldn't be there and tries to fight them themselves. We do sometimes use a chemotherapy drug into the bladder instead, And there could be quite a few reasons why we might do that. One might be that there's no BCG available in the world, which happens quite frequently. It's been a big issue again this year, unfortunately. And I think there's a lot of reasons for the lack of supply. Sometimes it can be that from what I understand from the pharmaceutical companies, that a whole batch of the bacteria didn't grow properly, or that the potency wasn't quite right. So you kind of get a month or two where there's just no BCG available to distribute. We think that COVID probably impacted a little bit this year, and that shipping it into the country became more difficult. And we've had to use a lot of different strains of the BCG. So lots of different countries make their own kind of BCG. So sometimes it might vary midway through the treatment, or needing to start on a strain that we don't know quite so much about. But the chemo might be used, so if we don't have the BCG, or maybe you've had BCG before and it's not working, so we want to try something different. So the chemotherapy works a little bit differently. So that's not stimulating your immunity. It's a treatment that's trying to basically directly poison the cancer cells to kill them, stop them growing and dividing. And if you kill them off, hopefully they can't, get any worse within the bladder. And the treatments that you've probably heard about is the mitomycin that we talked about before, that you can give as a single dose after a cystoscopy. You can use as a course of treatment like the BCG. So you could give it, like, as the 6-week treatment, and then the maintenance with the mitomycin. If anybody here has had that, you might know it's a bit of an issue with the PBS, or the government doesn't pay for mitomycin. So sometimes there's an out-of-pocket cost associated with that. Or another drug we use called gemcitabine. Gemcitabine is a drug we use quite a lot in people with more advanced bladder cancer, given intravenously, but if you give it into the bladder, it seems to work quite well as well. And I know one of the questions was about using a combination of 2 chemo drugs together. And that's giving basically one drug after the other, still both straight into the bladder, but needing to put one drug in, wait for the 2 hours, let the drug out, and then give the second one. This is a reasonably new treatment, and it was presented when I went to a conference in San Francisco just before the world shut down, where they were looking at techniques and treatments to use if there wasn't BCG available, or for people who the BCG hadn't worked and they really didn't want to have their bladder out. So the 2 chemo drugs given together, we hope, might be more potent and more effective than giving one drug on its own. But it is a reasonably new treatment, hasn't been used in large numbers of people, but certainly in small trials with a few hundred people, it seems to be quite effective in the people where we couldn't get the BCG or had some reason for not having it. But it makes treatment obviously twice as long because you have 2 infusions. Yeah.
And so is the synergistic effect supposed to be more effective?
Yeah, I'm not sure whether it's synergistic through the drugs with each other, or that you're just kind of the 2 drugs being quite different and killing cells in a different way. Just like when we give combination chemotherapy intravenously, we're basically kind of trying to prevent cell growth by attacking in 2 different methods. Yeah, I'm not sure whether they kind of activate each other, or whether it's just kind of the cumulative effect of giving 2. But we've started trying to get that approved at a few of our hospitals because of the BCG shortages.
But we don't know the long-term benefits.
No, it seems to have been quite a recent thing that's done in only small numbers of people so far. But we have got a few people having it at St George for either the recurrence of the cancer was really small, so it was kind of too extreme to go straight to removing the bladder, or that we couldn't get BCG and it was high grade, and we felt that it'd be more effective than one drug on its own.
And do you think there's superiority to mitomycin, the combination gemcitabine docetaxel?
Yeah, I haven't seen this as they're kind of compared head to head. We know that mitomycin versus BCG, the BCG certainly wins. Not by a huge amount, but probably around that 5 to 10% better than the mitomycin. And I would assume that the combination of the 2 drugs would be more effective than mitomycin on its own, but I'm not sure if they've been tested kind of head to head to know that for sure. And some people may have heard about there's a trial being run by ANZUP, which is the Australian New Zealand Urology Group, which coordinate to try and run some trials both locally and coordinating with overseas. And they're doing a trial of giving the BCG and mitomycin in the hope that it might be better than one drug on their own. And that's given as not on the same day. So not like the gemcitabine docetaxel given one after the other on the same day, whereas the trial is alternating them. So giving 2 weeks of BCG, then 1 week of mitomycin. So there might be someone on the chat who's heard of that or had that treatment, and what we hope.
Yeah. Paul in our group, Paul had it. But he unfortunately had to go for cystectomy. Didn't work for him.
Yeah, it's hard to know. We've probably got about 15 people that have been through it so far. I haven't kind of got a good feeling for whether it seems to be better or worse than BCG on its own. Probably just too soon. But I believe they're about a bit over 50% of way through recruitment. So I think there's about 250 people maybe that are on that trial so far.
There was another question, just how often is maintenance?
So if I got it, I thought I put it somewhere. No. So usually is it
monthly?
Yeah, there's a few different schedules. So some studies gave 1 treatment per month as the maintenance, but more commonly it's given as cycles of 3, so that you do the 6 weeks in a row, and then at the 3-month mark doing 3 treatments, at the 6th month mark doing 3, and then going out to each 6 months. So I almost need to draw it out, but it's 3 consecutive weeks each 3 months initially, and then if everything stays clear, going out to 3 weeks each 6 months. And then it gives people bigger recovery times off treatment, I find, whereas the monthly, you kind of don't quite get over the cystitis kind of symptoms of urinary frequency and burning by only having kind of 3 weeks in between. But both schedules equally give the same amount over a 12-month period.
Patty, there's another question. If BCG, if cancer comes back after the BCG, can you then go and do BCG and mitomycin as the next option?
For the trial, they're using it as the first treatment. So it has to be people that have not had any treatment into their bladder before. We can do the other ones though. So if I go back to, so if you had just the 1 course of 6 BCG and something comes back, we would prefer to give another 6 weeks of the BCG, because some people it just takes up to 3 or 6 months for your immune system to get adequately turned on. So we'd usually try another 6 of the BCG if everything was tolerated okay. If it wasn't, for example, lots of burning and stinging and urinary frequency and just can't do another round of the BCG, we would then go to usually one of the chemotherapy drugs. And most of the time we're giving either the mitomycin or the gemcitabine on its own, but obviously try and get a feel for whether this combination gemcitabine docetaxel might be good, especially in someone who's kind of younger, fitter, haven't had too many bladder symptoms from the BCG. But yeah, it doesn't automatically mean that after 1 round of BCG that it's failed and you have to move on to something else. We give it a little bit longer usually. And I've also seen plenty of people who've had a course of BCG like 5 years ago and then something's come back and we've retreated again and that's worked again. Obviously, a lot of people wanting to know exactly what the chance of their cancer coming back is. And it's reasonably complicated because it depends on how big the cancer was, how many, was there just 1 or was there multiple inside the bladder? And this is just one of the calculators that can use. And you don't need to register or anything for this. Hopefully this works by clicking on it and showing you. There's lots of companies making them, but this is where there's quite easy little drop-down calculator without all the ads, if we can stop them, running, where you can kind of just pick whether, if there's just 1 cancer, if we know how big, usually it's just bigger or smaller than 3 centimetres. Usually the surgeons will know that, or it might be on the report. And then if it's come back before or not, so is this the first time that a bladder cancer has been found, or has there been multiple found and this is like the 3rd or 4th time it's come back? You kind of pick on there. The stage, so the TA being no evidence of growth into those lower cells of the bladder, or maybe it has gone a little bit deeper. So this is off the pathology report. So I sometimes do these little calculators with patients, so because you need the pathology report to do it. And then also whether there was the carcinoma in situ, so those cells growing in the surface, and then just whether it was high grade or low grade. We don't really ever see this grade 2 reported. We seem to get low and high. And then it calculates down the bottom here what the chance of your cancer coming back is. So the dads don't want to stop. But looking at you know, in 1 year. So this is assuming that the only treatment was the cystoscopy. So if you didn't kind of do any of these intravesical treatments, what's the chance of it coming back? So these are kind of showing at the 1 year mark, the 38% chance of something growing back, at 5 years being out to 62, and progression is it getting worse at that 1 year. So recurrence is just growing back again, but not necessarily being more aggressive. And then there's ones down the bottom, the progression being, does it learn to grow deeper roots and become a more serious problem? But yeah, there's lots of different companies that do these things, and it gives us an idea of the chances. And obviously, if you can see that, look, there's a 50% chance of something coming back, well, then it's definitely worth having one of the treatments into the bladder afterwards to try and reduce that. And it seems to be that doing a course of the intravesical treatment approximately halves the recurrences. So if there was a 50-50 chance, it might take it down to more like a 25% chance something would come back. But it's quite hard to completely estimate that for everybody, just because it does vary so much. So if you kind of play on here and you go through and say, well, there's actually 8 tumours, well, that makes a very big difference. So I kind of go on a rule of thumb of about halving the recurrence rate by going through the BCG after. So obviously it doesn't take it away altogether, but certainly drastically reduces the chance. So let me see if I can get the presentation to come back up.
While you're switching back, Paddy, there was a question related to HIVEC. I don't know if you're going to mention, which is basically heat. It's heat-induced mitomycin, isn't it? It's supposed to increase effectiveness. Is that true or not?
We don't have it. I don't know of anyone in Sydney or Australia. There's probably some units that have it. It is supposed to be slightly more effective, but I'm pretty sure it's only tested in the people where BCG has kind of stopped working, and then using either standard mitomycin or heating it. The heating seems to make it slightly more effective, but I don't have kind of personal experience of that. Not sure if you've seen that done here or overseas. Or...
I think we might have one of our participants that's had it.
Yeah, it involves having a whole kind of special machine that keeps the chemotherapy drug at a certain temperature while they're infusing it into your bladder.
Another question that came through earlier was very interesting and topical. When the COVID vaccine comes out, would you advise it in someone who's having BCG treatment?
It would depend on what the vaccine ends up being. So I guess I don't usually have an issue with people having vaccines while having BCG. One of the trials for COVID, though, has been using BCG. So I'm not sure if that's one of the vaccines trials that have gone ahead. So I'm not sure how they were using it. I assume they were vaccinating people directly under the skin with a BCG vaccine to see if that helped reduce COVID, because that was one of the issues that led into the BCG shortages earlier in the year. That was the stockpiling for the trial. I can't see that there'd be a big problem with having any of the vaccines while you're having BCG. I guess it might potentially enhance or make you have more of a reaction to a vaccine, because your immunity might be slightly stimulated. But yeah, I wouldn't normally be something I'd be concerned about a vaccine during that treatment, like we would sometimes hold off with chemo.
And people having intravesical chemo and systemic chemo?
Yeah. So I guess with the intravesical chemo, because we know very little of that goes into your bloodstream, it shouldn't actually affect your immunity. So vaccines should be fine in that situation. With people having intravenous chemotherapy, obviously we do have to be a little bit more careful with the timing of vaccines. And there'll always be information that probably needs to come from your GP or someone looking it up, is whether it's a live or a dead vaccine. So some vaccines give you a little bit of a dead substance that tries to stimulate your immune system, and there shouldn't be any risk with that, because it's not giving you any live organism or live bit of bacteria. But some vaccines, like BCG, actually, when they use it for tuberculosis, it's giving you a little bit of a live infection, and that is usually held off when people are having proper intravenous chemotherapy because of the risk of infection with that. So it depends on which COVID vaccine gets through, I think.
Yeah, it's probably going to be the Oxford one, I'm sure, because the temperature doesn't rely so much on temperature extremes. I just wanted to say, Tom is one of our members who gets the heated mice, and he said it's specifically heated to 43 degrees. Just before you go on, sorry, there were questions that came through before today. When is it time to stop BCG treatment with low-grade TA, high-grade TCC diagnosed 3 years ago? And it's been evident on every second cystoscopy.
So continuing to show recurrence every second.
Yeah.
I guess it was continuing to occur despite having the maintenance BCG. You really should be thinking about switching treatment. If it was, I wouldn't just kind of keep giving the same thing over and over if they were continuing to grow back. I've never given more than 3 years, but that's usually when someone's had multiple clear cystoscopies and we're just completing the maintenance. I think if there's every second or third time a cancer's growing again, then probably the BCG is not adequately controlling it. Maybe you should switch treatment.
Okay.
Yeah.
All right, I'll let you proceed.
So that was kind of where I was stopping on the non-muscle invasive bladder cancer. So if there's anything else there that you thought was BCG related or intravesical chemo related, let me know. Otherwise, I'll kind of go on to the more serious end of the talk.
Patty, there's another question. What about Keytruda? Does it work for non-muscle invasive high-grade cancer?
Still in trials. So Keytruda, for the people who might not know what it is an intravenous immune therapy drug that has been very successful in a number of advanced cancers. So it's currently approved for, I think, melanoma, lung cancer, for bladder cancer when it's spread, so when it's more advanced, along with kidney cancer and a few others. But there's ongoing trials, of which there are a couple in Sydney, using Keytruda for people where BCG has stopped working. And that's being run through, closest to us is the Northern Cancer Institute in North Sydney. I'm sure there's quite a few other sites that are doing that. But basically, we hope that it does work in non-muscle invasive bladder cancer, but not to the point where we would say that we can't prescribe it yet. It's still under trials to see if it does help. And that's very similar to the trial that we're getting at St George, is giving a competing drug called nivolumab, which is just a different company making a similar thing to Keytruda, in exactly those patients where the BCG has stopped working, but we're trying to find something we can do rather than just take the bladder out. So hopefully it will. We'll watch this space for the next couple of years, I think.
Thank you. You can proceed.
So muscle invasive bladder cancer is when it's grown kind of deeper roots into that muscle layer of the bladder. We'll go back to the picture in a minute so I can show you exactly. But why is it bad if they say on the pathology report that it has grown into the muscle layer? That's mainly because blood vessels and the lymph vessels that drain to the lymph glands run in that muscle layer. So if the cancer cells have invaded into the muscle layer, well, then the potential for it to get into the bloodstream and go beyond the bladder to other organs or lymph nodes nearby, that risk is much higher. When it's just superficial, really, it can't get near the blood vessels, or very, very unlikely to, but muscle invasive can. So the treatment is subsequently more aggressive for that, to try and mop up anything that could have already escaped the bladder. So that on this little picture, and I'll go back to the previous one, is the right-hand side here. So all these ones, you'll see the little yellow blobs are starting to grow into that the deeper layer underneath. And where you can see the little pink dots, which are muscle fibers, in between will be where the blood vessels and everything run. So if it's grown all the way through like this, it could well have actually grown into a blood vessel on the way as well, and then potentially break off and go outside the bladder. Go back to this one. So what's the treatment when it's become muscle invasive? Well, the number one is usually surgery, looking at consideration of removing the bladder and the lymph nodes nearby, to basically as a curative kind of thing, to try and get rid of where the cancer is and cure you of the cancer altogether. We are more and more starting to use chemotherapy as well. And ideally, the best results are if someone has chemotherapy first, so before their surgery. And I think I go on to come talk a bit more about that. But the role for the chemo first is obviously trying to shrink the cancer that's in the bladder and hopefully make the surgery a little bit easier. But also, if some cancer cells have broken off from the cancer and are circulating in the body, then you're mopping them up as early as possible with some chemotherapy first. And the chemo I'm talking about in this situation, though, is giving it intravenously. So coming into a chemo suite, having a drip put in your hand, and chemo drugs going into the bloodstream, not just into the bladder. Because if you give the drugs just into the bladder, even though it's going deeper, you're really just kind of coating the surface of it, and you're not getting to the deeper parts of where the cancer's growing. If obviously someone is not fit for surgery, and that could be because of other health problems like heart problems or lung problems, and they might not be fit enough to safely make it through a big surgery, there might be a combination of chemotherapy and radiation given together, or radiation alone. Let me go this one. Okay, I've gone through there. So what is the chemo that we use? And as I said, the chemo is thought to be more beneficial prior to surgery, and you might see the word called neoadjuvant, which just means prior to surgery. So these are much more of your traditional chemotherapy that you hear about people having. So, the side effects of being the tiredness and nausea and possibly losing a little hair, that's kind of things that can happen with this chemo. And the goals there, obviously, as I said, was to shrink the primary cancer in the bladder, but then also to treat anything that was microscopic. So that's something that's not detectable on a CT scan or a bone scan, but could potentially be floating around in the bloodstream that we can't pick up. And the thought with any chemo that's given prior to surgery in lots of different cancers is that it basically allows the treatment to start much sooner. So rather than having to go through surgery and giving any of those little microscopic bits 2 or 3 months to grow, you're getting onto it straight away as soon as you've been diagnosed. Also gives us an idea of how the chemo works. So if you have some chemo before surgery and then have the bladder removed or a cancer removed, and we can see that nearly all the cancer cells are dead, well, then we know those chemotherapy drugs were really, really effective. Whereas if you have the chemo first and at the time of surgery, there's still quite a lot of cancer cells that are alive, it means possibly something was resistant to that chemo. We might need to give something more afterwards or think about other treatments. It's not always possible to give chemo first. So sometimes the cancer within the bladder has actually blocked the flow of urine. So on one side, it might be that the ureter, which is the tube that drains from the kidney to the bladder, gets blocked, and that we see on the blood the kidney function tests are not very good. And so it might be that it's not safest to give chemo first and might need either a stent put in or might have to have the surgery first. So what chemo drugs do we use, or what we call them kind of chemotherapy protocols, which is what combinations and how are the schedules given. Most commonly, it's 2 drugs together, either cisplatin or carboplatin, and they're very similar, but the cisplatin relies more on the kidney function, so sometimes we can't give it, in combination with gemcitabine. Or some of you may have heard of a very toxic chemo combination, which we don't use very much because of how hard it is for people to get through it, called MVAC, and that's 4 chemotherapy drugs given together. And as you can imagine, if people feel crook and run down on 2, they feel twice as bad when they have 4 all at the same time. So that's kind of reserved for the fittest, youngest people that we think can get through that. And usually it's given for a maximum of 12 weeks before surgery. So we don't want to delay the surgery for too long. So if you're having lots of side effects from chemo, we need to delay it or change doses. We don't really want to wait more than that kind of 12 weeks before we get on with the surgery. All chemo given like this is still as an outpatient, which means you come to a chemo suite on the day or the hospital on the day, have a drip put in the hand, the chemotherapy runs through, and then you go home again the same day. So it doesn't require staying in hospital unless there's complications or you feel sick afterwards. Obviously, that might lead to coming into hospital, but most of the time it's coming into the chemo suite for a couple of hours, having the treatment, going home again the same day. If the chemotherapy is given before surgery, majority of the time there's no need for any further chemo afterwards. Whereas if obviously it can't be given before surgery, we then assess whether someone's fit enough or well enough after their big operation to have it after the surgery. So I won't go into too much detail about the actual drugs and what the side effects and things are. If people had specific questions about those, about the scheduling or anything, kind of not knowing the audience of whether most people here have got early bladder cancer or what they're having. I won't go too much, but very happy to answer more about those. Immune therapy drugs, so things like the Keytruda and everything that people are asking, have not yet kind of been proven at this stage to have prior to surgery, and they're also trials that are ongoing, combining the chemotherapy drugs and Keytruda together to see if that's actually more effective. But at this time, we don't know that, only available through a trial.
Paddy, maybe you're still going to talk about the side effects of chemo, but a question came through, keen to understand some potential impacts that intravenous chemo treatments cause down the track. Obviously, different chemo combinations mean that no two scenarios may be the same, but can result in further medical conditions, i.e. can make you more prone to developing other cancers or cause long-term issues with other parts of the body.
Yes, I guess because it's different for different schedules, I wasn't going through it in detail, but across the board for the two that we use predominantly, the cisplatin and gemcitabine, or the carboplatin gemcitabine, there's usually biggest side effects would be fatigue, and that tends to build up the more chemo you have. So the first treatment, you might find you're really run down for 2 or 3 days, but then bounce back. But by the 4th round, you might find that actually you're pretty tired for the whole 3 weeks. Nausea can certainly happen, but the medications we give to stop nausea and prevent and treat the nausea are pretty good now. So it's really very uncommon for someone to come back and say they vomited, for example, but might be a little bit squirmish for a couple of days after treatment. Can get lose your hair a little bit. Usually these drugs only cause some thinning of the hair, so it's not like someone having breast cancer where they lose it all and need to wear a wig or a scarf. It's usually just some thinning of the hair that you can kind of get away without too many people noticing. But kind of the question was also, long term, what can it do? They do, obviously, during the treatment, you have a lowering in your immunity, so risk of infection substantially increased. Chemotherapy does seem to have some effect on blood vessels and heart disease, so that can go up a little bit later. Your risk of heart disease definitely goes up. There can be some hearing damage with the cisplatin, so it can cause some ringing in your ears or some hearing loss. So occasionally, especially in men who have worked in, have been a tradie or worked around very noisy professions, might already have some hearing loss, and we might find that that's unmasked by them having the cisplatin. It brings on the ringing or the hearing loss really quickly, so that can be worse down the track. The 2 drugs we commonly use don't really have an increased risk of secondary cancers from those drugs. Within the MVAC, the 4 drugs given together, there was a slight chance of secondary leukemias from the chemo drugs. But the chance of that's obviously extremely low compared to the chance of the bladder cancer itself spreading. So there's a weighing all those things up of, we go, look, if we don't have any treatment now, this bladder cancer is going to come back for sure, versus, a 1% chance, well, more, actually less, about 1 in 1,000 chance of secondary leukemias from the actual treatment. But obviously, if someone's really sick and get lots of side effects and in and out of hospital with infections, you can be quite run down. Losing muscle and weight and that kind of thing during chemo, although we try to make adjustments to that early on if those things are starting to happen, and especially if it's given prior to surgery and there's lots of side effects, we would rather bail on the chemo and get on with the surgery.
Judith had mentioned, I'm not quite sure exactly what she was saying, but she said doxorubicin was added to the MVAC OFLSTA.
Oh, yeah. So doxorubicin is the same as adriamycin. So just to keep it simple so that the MVAC made sense, I called it the trade name, which is adriamycin, to keep the A right for the MVAC. But yes, doxorubicin and adriamycin are the same thing.
Got it. Thank you.
Yeah.
Good. That's answered some questions for now. There are some prognosis questions coming up, but I'm sure you'll get to that. Do you want to finish your talk and then I'll...
No. I haven't kind of specifically gone into prognosis because of it being so specific, depending on how aggressive cancer was in an individual person. So,
well, let's say, and I hate personally being asked these questions, but because we're not God and obviously we can't say how long people are going to live. I don't think I could have done oncology for that reason, because it's all about...
and the stats they're only statistics, and the numbers don't mean much on a one-on-one basis.
No. And you always hear the story of, my doctor told me I had so many years to live, and then I lived an extra 10.
Yeah.
So, but the question was, let's say for the average person in this group, who's had straightforward muscle invasive, T2 disease, had a very successful surgery, tumor was taken out, lymph nodes are negative. What's the long-term prognosis?
Look, I'd be guessing at probably, maybe about a 15 to 20% chance of something coming back in that kind of situation, especially if there's been a really good response to the chemo and safely got through their surgery. When I've got plenty of people that have all of that done, and then we're following them up with their scans for 5 years and nothing comes back, and we don't kind of keep following up beyond that. But the risk of it coming back obviously gets higher the more aggressive the cancer was. So if at the time of surgery it was found to be going through the other side of the bladder and possibly going in a female near the uterus or in a man near the bowel or something, then that risk is much, much higher. Or if the lymph nodes had cancer within them, of course, then we would be more suspicious that something might come back and probably follow those people up more closely. Yeah. But yeah, the prognosis is very hard, and it sometimes is very hard for people to get their head around those numbers because, for one person, either your cancer comes back or it doesn't. It doesn't matter if the stats were 10% or 50%, but it does help us identify or choose who we think is worth going very aggressively and very hard with their treatment versus someone who had an early cancer. We wouldn't want to go through all of this if it changed this outcome by 2%. Yeah.
What about someone who's got high-grade non-muscle invasive? Is it curable with treatment, or is the end result that it will eventually go to muscle, will eventually become muscle invasive?
No, the majority of cases, like in those kind of situations, it would be cured. So it sounds, and a lot of people kind of think that it's all doom and gloom when they get that high-grade pathology, but the vast majority of people get through their intravesical treatment and are cured of it. And for example, when we just put a few of those false, made up numbers into the calculator, even with a high grade with multiple tumours, the recurrence rate was about 30%. So vast majority of people with non-muscle invasive bladder cancer are cured of it, and only a very small proportion would need to go on to think about the salvage treatments or possibly having their bladder removed if it's early. Obviously, in a small percentage, they go through that treatment and then years later it can still come back, but it's only a small percentage.
How do we have time for a little case scenario? One of our participants, they had a cystoscopy and biopsy in September 2019 for a large papillary urothelial carcinoma high grade. There's a deep laminar propria invasion up to 3 millimeters in depth. The muscle is present in the biopsy and appears unremarkable. He started BCG 6 treatments in January 2020 and had a second cystoscopy and was clear in March, but started BCG 3 booster treatments in April with a third cystoscopy in June, which is also clear, but started a second BCG 3 booster treatments in August and will have a fourth cystoscopy in December. Scheduled to start a third booster 3 treatments in February 2021. How long is the cycle of cystoscopy and booster treatments likely to go on for if the cystoscopies continue to be clear?
So that was high grade with laminar propria invasion. Is this like a T1?
Yeah.
Yeah.
Yes.
Yeah. Ideally, I'd be trying to give up to 3 years of maintenance in that situation, but it gets less and less frequently. So I think you'd kind of describe someone having an induction and then 2, maybe 3 rounds of the 3 monthly. Usually after that, we would go out to those booster or the top up maintenance treatments once every 6 months. So 3 treatments every 6 months. And I wouldn't like to kind of guess what the urologist is doing. Some of them watch really closely and continue the 3 monthly until they've had 4 clear in a row. Others will quite quickly back that off once there's been 1 or 2 clear cystoscopies in a row out to 6 monthly. But I know a lot of people do get very frustrated with the endless cycle of feeling like they're constantly having anesthetics and biopsies and recovering and then going straight back to BCG. So we do say, look, 3 years would be the absolute longest we'd ever do, but we make sure that we touch base every 3 to 6 months and see how people are going and are they willing to keep going and their side effects getting worse. Because what can happen when you have more and more and more BCG over your life is it does shrink your bladder with time, and you can find that the bladder gets more scarred and you can't hold as much urine and you're going to the toilet more frequently, and that can be permanent if you kind of keep pushing on despite those symptoms building up. So if we've got through 12 months and everything's really clear, but yet the side effects are really building up, that's when I'd like to think about having a break and maybe saying we only restart if something comes back on a cystoscopy. But it's a bit unpredictable. Some people get through 3 years and hardly skip a beat and the bladder functions absolutely fine and nothing happens. Other people get terrible cystitis treatments after 1 round. So it's just playing it by ear. But the longest I'd ever do, I've never done more than 3 years for someone who's been clear really since the start.
We had a question about BCG, and so leukocytes are non-specific, so lots of things can cause leukocytes in the urine, from fungal infections to just inflammation. All those things can cause leukocytes. It doesn't necessarily mean you have an infection. Normally when there's nitrites with the leukocytes, that's when we worry, or positive urine culture, or you're symptomatic. Which is obviously difficult if you're undergoing these treatments, because after a lot of them act like a UTI. Patty, you probably want to add something else?
Oh, so I kind of expect to see some leukocytes during BCG, because the treatment we're giving is trying to inflame your bladder and trying to make your immune system turn on. So it's kind of expected to see leukocytes on the dipstick when the nurses are checking it. And as long as you don't feel too bad with that, and you don't have fevers, and you don't have other symptoms of urine infection, I would usually just go ahead with the treatment and say, look, that's expected side effect.
Thank you. I think we did touch on it earlier, but Michelle's asking, I can't have BCG. What are the alternatives? I guess BCG intolerance. What would you do then?
Yeah, so that's when I would look at switching to one of the chemotherapy drugs usually. If the side effects in the BCG are really bad, like sometimes people come and say they've had to go to the toilet every 20 minutes or every 30 minutes for days on end, then we think maybe the immune system is kind of overworking and that the bladder's just really super inflamed, and we might give some steroids or something like some prednisolone to try and calm the bladder down. But if that doesn't really help and the side effects are just bad from the BCG, then we would switch to one of the chemotherapy drugs given in the same schedule. So still into the bladder, but just changing the drug over. And the chemo drugs don't seem to inflame the bladder anywhere near as much as BCG does. And people get some weird side effects sometimes from BCG. Occasionally you get someone who has bad arthritis. They must be.
Yeah, we had someone.
Yeah. They must be absorbing a little bit into the bloodstream and causing arthritis. And then especially if they've had to see a rheumatologist or a joint specialist, they'll sometimes say, look, I really think it's the BCG causing arthritis and we need to change the drug.
Yeah, one of our participants had that. Yeah. Now, how quickly can high-grade non-muscle invasive cancer become muscle invasive? If you're having 3 monthly cystoscopies, will that be enough to pick it up?
Yeah, I can't really think of the last person actually who had it progress to muscle invasive during treatment with 3 monthly cystoscopies. It'd be very low chance when you're being surveyed that closely with 3 monthly. It's much more commonly seen as like when you first diagnose someone's just already muscle invasive when they first have a cystoscopy, or there's been a break in treatment, or there's been a kind of delay with having it done. But I can't think of when it's been watched that closely that it's really progressed in anyone off the top of my head. So I would have thought 3 monthlies, you wouldn't want to do them closer together than 3 monthly, and that would be plenty to pick up any changes. You usually just see that it was becoming the T1, so getting that very early invasion rather than jumping straight from that to muscle invasive.
Yeah. Claire, she's asking on his behalf. He had a T1 high-grade tumor that was successfully removed by TURBT. Subsequently, had 6 weeks of induction immunotherapy, and the cystoscopy after that showed no recurrence. He's gone on to maintenance, 3 months so far, and the 2 cystoscopies he has also shown no recurrence. However, if the cancer occurs later down the track after maintenance is stopped, could it be treated by surgical removal and further immunotherapy? Or at what point would there be a decision to progress to cystectomy, and are there particular circumstances that would trigger this? Does it depend on whether it occurs at low or high grade? Is it worth mentioning he's 45 and has smoked for most of his life, but only just recently quit? That's a long, loaded question.
I guess if there's been a decent gap between the maintenance BCG and it coming back again, you could absolutely retreat with BCG. I've done that in quite a few people. I've had a whole course and then 3 or 4 years later it comes back and we just treat again. Especially, and the longer the gap is, the more likely it is to work again. Like if you stopped it 6 months ago and it's already back, I'd probably look at other options. But in people that are young, obviously we don't want to take too much of a risk of something progressing and becoming muscle invasive, so we'd have a lower threshold for looking at being aggressive with surgery, especially if it's kind of proven to be high grade again pretty quickly. What point would there be a decision to progress to cystectomy? I guess if there'd been a decent gap between the BCG and it coming back, and then we gave another induction and it still hadn't cleared, you'd kind of almost have to say the BCG was failing in that situation. Yeah, or if it's becoming more aggressive each time, you'd kind of certainly jump to cystectomy earlier. So yes, does it depend if low or high grade? Yes. So I guess if it's little low grade ones that are coming back all the time, we wouldn't want to go straight to removal of the bladder. We would probably look at trying other intravesical therapies.
I hope that answers your question, Claire.
You would like to preserve. The other thing is, and I only kind of touched on it very briefly, is we do sometimes go to combination chemotherapy and radiation in people that have got lots of recurrences in the bladder, but a very strong preference to keep the bladder. I've only ever done that combination once or twice in people with the T1, so it's starting to get those deeper roots, but not yet become muscle invasive. There's a thought that the combination could be helpful in that situation. Hasn't been tested a lot though. In terms of trials, and I've only done it in 1 or 2 older people who are potentially not fit enough to have their bladder removed. But in young people, I guess, yes, of course, we want to preserve bladder as long as possible, but we want to preserve their life more. So we don't want to miss the boat.
Yep, yeah, that's true. Patty, what are the strengths and weaknesses of viewing a PET scan for bladder cancer?
Yeah, I saw that down here. I really quite like PET scans in terms of looking for any spread of bladder cancer, but it's not at all helpful for looking at the bladder and the ureters themselves, really, because the dye that you give is a radioactive sugar and it gets filtered by the kidneys. So what happens on the PET scan is that the kidneys, the ureters and the bladder go black no matter what. So it makes it really hard to actually examine the primary cancer in the bladder. But it is very helpful for seeing if there's anything in the lymph nodes or spread anywhere else in the body. They're not funded by Medicare in bladder cancer, so we don't use them all that much. But occasionally someone just says, look, I want to have a PET scan anyway, and they pay to have it done, and I find that it can be really useful for picking up really tiny lymph nodes. So people in the chat may or may not know a CT scan is kind of like a black and white picture. Just shows us if something is big or small. It won't show any what's going on inside something. Whereas a PET scan will only show up as these little black marks on the PET scan if there's activity, so if there's growth inside something. So it means even if a lymph node is only 5 millimeters in size, and we normally would have completely ignored it on a CT scan, if it's shown a lot of activity inside on a PET scan, it's much more suspicious of something having spread. So I think they're helpful. We don't do them all that often, only because of the cost of them and because it can't assess the bladder itself properly.
A question relating to CBD oil, which we were chatting about in our Q&A session last week. Does it impact on chemotherapy in any way, or are people free to use it?
I don't think so. I've got a lot of patients who use CBD oil as an alternative to anti-nausea drugs, people that get really bad nausea and find that either they have side effects from traditional anti-nausea medications, or it's still bad despite that, and they use CBD oil. There's not much proof that it has a lot of anti-cancer effects, so I wouldn't kind of recommend it as a cancer treatment, but I don't have an issue with people taking it at the same time as their chemo if it's helping with their symptoms otherwise.
Yeah, and that includes intravesical.
Yeah, absolutely. With intravesical, I can't really affect it at all. I can't see how someone hopefully would get any side effects or symptoms that would require CBD oil while having intravesical treatment, but they wouldn't interact.
Yeah, thanks for just sharing your expertise and your knowledge and years of experience.
Oh, you're welcome. Thanks for the invitation to speak.